Today we're going to cover the lymphatic system, and the lymphatic system is made of many different components, including lymphatic vessels, which are responsible for transporting a liquid known as lymph, which is collected from the tissues and organs of the body, and then it's released into the large veins. Small diameter lymphatic vessels, or lymphatic capillaries, are mainly found throughout our loose connective tissue of our dermis, and they're also found in the intestinal mucosa. These ducts are closed at one end, whereas the other end fuses with other capillaries to form larger ducts known as lymphatic vessels. In turn, lymphatic vessels join to one another and form larger vessels. Finally, the largest lymphatic vessels release the lymph into the large veins located in the neck between the jugular and the subclavian veins. And listed on this slide and depicted in the picture are all the components of the lymphatic system. So it's not just the lymphatic vessels and the lymph nodes. It also consists of the spleen, the Peyer's patches of the intestine, the bone marrow, all the lymph nodes that are listed here, as well as the thoracic duct, which we're going to talk about in drainage, as well as the cervical nodes and tonsils and thymus. So when we're talking about the lymphatic system, keep this image in your mind and refer back to this image if you need a good reference for what the lymphatic system is actually comprised of. As we go through pathology, we're going to build on older concepts which we've already covered. So we've dove deep into the mechanisms of the immune system. We talked about the innate versus the adaptive immune system. We mentioned how the lymph nodes are involved in the immune response, but we didn't get into too much detail about it. But the lymph nodes are directly involved in the lymph nodes in the lymphatic system are directly involved in the immune response, as the lymphatic system clears away infection and keeps our body fluids in balance. So again, depicted on this slide are all the different components of the lymphatic system. We also have adenoids and tonsils, which I've mentioned previously, and our adenoids and tonsils are responsible for trapping germs that come in through the mouth and the nose. And the lymphatic system as a whole is a pressure-driven system that's based on the principles of osmotic diuresis. And osmotic diuresis is increased urination due to the presence of certain substances in the fluid that get filtered by the kidneys. This fluid will eventually become urine, and these substances can cause additional water to come into the urine and increase its amount. So lymphatic system associate that with osmotic diuresis as well as the immune response. And then the question arises, what happens if these substances, which are made of water and different types of protein, what happens if they accumulate in our tissue spaces? Well, we're going to talk about a lot of the pathologies that are associated with this, and the first one we're going to talk about is lymphedema, so swelling somewhere in the body caused by lymph accumulation. And the protein that we're referring to is a result of cellular metabolism, and it's not related to the protein that's ingested from food. So you may be asking yourself, what is lymph actually made of? Well, it's mainly made up of white blood cells, especially the lymphocytes. As we know, the lymphocytes are directly involved in the immune response, and the lymphatic system is a direct modulator of the immune response as well. So lymph is made up of white blood cells, especially the lymphocytes, and fluid from our intestines called chyle, which is spelled C-H-Y-L-E, and this contains proteins as well as different types of fats. And the lymphatic system as a whole is composed of superficial and deep lymph nodes and lymph vessels. The lymph vessels drain the excess tissue fluid, volume, and plasma proteins that remain in the interstitium after normal capillary perfusion or filtration has taken place, and then they're responsible for returning it to the central circulation via the large veins in the neck. All the lymph fluid is eventually going to pass through the lymph nodes before emptying into the right lymphatic duct and the thoracic duct. The fluid can then be returned to the bloodstream via the left and right subclavian veins. And as depicted here, this is what happens as protein is passing from the capillaries into the interstitial fluid and then migrating into the lymph nodes and then finally getting drained by the subclavian vein. So This schematic depicts the passes of protein, which again are represented by the little dots in the picture, from the blood capillary through the tissue channels into and throughout the lymphatic system, and then back to the venous system. And again, it eventually will empty into the subclavian vein. There's a lot of different molecules that are too large to pass through the venous endothelium, and these will get filtered out or not make it into the circulation at all. This slide is mainly here for your reference. This is a very in-depth and intricate drawing of how the lymphatic channels are running through the different skin zones, the different components of the lymphatic channels. Don't worry about this too much. We're going to cover this a little more in anatomy. An easy way to think about the lymphatic system is to think about the expressway, think about a toll booth, and think about cars traveling through the toll booth and through these different lanes. So let's say that the highway lanes are representing the lymphatic vessels. The lymph nodes are going to be represented by the toll booths, and the lymph are represented by the cars that are being transported on the highway. As long as the number of cars, which is the lymph load, is equal to or less than the number of lanes open, hence the lymphatic vessels, there's homeostasis. If there's an increase in the number of cars due to any type of acute injury, infection, or inflammation, well, then there may be a temporary traffic jam. The traffic jam represents edema, and then the edema can resolve after time. Another way to look at it is if the toll booths are closed, that's indicative of some type of lymph node resection or some surgery that altered the lymph node function. Then the transport capacity in the highway is reduced, and even though the number of cars on the highway is not increased, so the lymph load is stable, the traffic, which is the lymph, builds up and lymphedema develops. So whether the cars are accumulating due to not too many lanes open, or the cars are accumulating because there's too many cars, these are examples or representative schematics that you guys can use to help yourself understand how lymphedema can occur. This slide represents the medical terminology that I want you all to know for the lymphatic system. So let's start with lymphangitis. Lymphangitis refers to the inflammation of a lymphatic vessel. Lymphadenitis refers to inflammation of one or more lymph nodes. And lymphadenopathy refers to an enlargement of the lymph nodes. So remember, the lymph nodes act as defense barriers and are secondarily involved in virtually all systemic infections and in many neoplastic disorders that arise anywhere in the body. We're going to cover this component more in cardiopulmonary, but I want to introduce Starling's theory of fluid dynamics. This slide basically represents a schematic of all the different pressures that are moving in and out of the cells and the tissues, and these pressures determine how much fluid moves and where it moves within the body. So we're going to start with the first pressure, known as plasma hydrostatic pressure. This is the pressure that's inside the capillaries that decreases as fluid passes from the arterial to the venous side of the capillary loop. Then we have tissue hydrostatic pressure. The tissue hydrostatic pressure is the pressure of the fluid in the tissue channels. And this pressure is usually negative or less than atmospheric pressure. And it tends to pull fluid from the capillaries into the tissues. The plasma colloidal osmotic pressure is the next pressure we're going to talk about. And the plasma colloidal osmotic pressure is caused by the plasma proteins. And this particular pressure creates a siphon effect and pulls fluid into the capillaries. And then finally, we have the tissue colloidal osmotic pressure. And the tissue colloidal osmotic pressure is the pressure caused by plasma proteins in the tissues that causes a net movement of fluid into the tissues. So again, we're going to cover this again in cardiopulmonary when we talk about tissue dynamics, but I wanted to introduce Starling's theory of fluid dynamics in this talk. This slide shows what happens if there's a rise in tissue hydrostatic pressure. So the lymphatic vessel that you see on the left that is represented by the letter A, this is a normal lymphatic vessel at a fairly low tissue hydrostatic pressure. and it's undergoing normal lymphatic drainage. Whenever there is a rise in tissue hydrostatic pressure, this is going to result in what we see in the picture represented by B. So the tissue is going to respond to this tremendous increase in THP, and the swelling in the interstitial tissues pulls on the anchoring filaments, and this pulling causes these filaments to open the initial lymphatic endothelial junctions, and this allows fluid to pour into the initial lymphatic vessel in an attempt to reduce edema. This slide here shows a picture of 3 lymphangions. The lymphangion is the functional unit of a lymph vessel, and many lymphangions may contract at once, but sometimes only one lymphangion is actually triggered. The pressure that's exerted by each lymphangion is usually a few millimeters of mercury, but at times it can be greater than 100 millimeters of mercury if the outflow is obstructed and many units are contracting at once. Contraction is triggered by distension. For example, if there's a large amount of filling, this is going to create a greater force. But this can be modified by humoral and nervous factors. The humoral factors can also include medications. Pumping is greatly aided by varying total tissue pressure, and this different tissue pressure can come from adjacent muscles, can come from respiration, or manual lymphatic drainage. And high intravascular pressure will fatigue the muscle wall, leading to ineffective smooth muscle contraction and ultimately leading to vessel failure. This slide here represents the regional lymphatic system, and it shows you the dermal and subcutaneous lymph territories. And the lymph territories can be divided into lymphatomes, and the lymphatomes are indicated by different shadings, different colors of shading that you see here. And the lymphatomes, they're separated by watersheds, which are marked by all those little equal signs together. And the arrows that are in the picture, the arrows represent the direction of lymph flow. The normal lymphatic drainage is away from the watershed, but collaterals will cross the watershed. The watershed's indicated by the thick double arrow. When the main drainage paths from each of these regions are blocked, lymph, which is denoted by the thick single arrows, has to be carried across the watersheds via the collaterals and the plexuses. The cutaneous lymphatic plexuses, also known as CLPs, are shown in the center of the chest only in this picture here. It's filled from the deep tissues and covers the entire body, and the different cutaneous lymphatic plexuses are not shown throughout the body here just to avoid confusion, but they do exist in other areas other than the mediastinum. These initial lymphatics will fill the superficial collectors. I didn't get into the superficial collectors too much, but if you go back to the slide that shows the intricate anatomy of the lymphatic flow, you can see the superficial collectors there. And the superficial collectors will drain into deeper ones and then fill into the lymphatic trunks, which are represented by the smallest arrows. And the lymphatome, or the external genitalias and perineum, are shown, but they're not labeled here. The thoracic duct, which is labeled in green, leads from the cisterna chyli to discharge into the left subclavian vein in the neck. The blood vessels are all shaded blue here for your easy viewing. The right lymphatic duct is also shown. It's seen on the figure on the right and depicted in green. And the right lymphatic duct carries far less lymph than the thoracic duct, and it's mainly responsible for draining the right arm and the head. It's also responsible for draining the heart, the lungs, and the anterior chest wall. And these two main trunks are sometimes linked by large collateral lymphatics. One thing really important to note in the clinic, and just for your general knowledge, is that normal healthy lymph nodes are soft and they should not be palpable. But palpable lymph nodes don't always indicate serious or ongoing disease, but this determination requires referral to a primary care physician, so the primary care physician can do the evaluation and actually make the correct diagnosis. Lymphedema is a swelling of the soft tissues that results from the accumulation of protein-rich fluid in the extracellular spaces. It's caused by decreased lymphatic transport capacity and or increased lymphatic load, and is most commonly seen in the extremities, but it can also occur in the head, the neck, the abdomen, as well as in the genitalia. So remember the slide where we talked about the highway and the toll booths. That's a really good schematic of how to understand lymphedema. So again, lymphedema is the swelling of the soft tissues that results from the accumulation of protein-rich fluid in the extracellular spaces. And lymphedema can be broken down into 3 stages. Actually 4 stages, sorry, because stage 0 is included. So stage 0 is the latent lymphedema, and in stage 0 there's going to be no clinical edema present. That's very important. That's a very important characteristic of stage 0. In stage 1, the lymph is going to accumulate and cause what is known as pitting edema. So these may look like little pits. It kind of looks like somebody pushed in on someone's skin, and that indentation that was made just stays. Stage 1 is easily reversible with elevation, and when the person gets up walking the next morning, the area may be normal size. But as the person goes throughout the day and is walking or running, the lymphedema may increase with any type of activity, and also if it's very hot out like we experience here in Florida, heat and humidity can also trigger the accumulation of more protein causing lymphedema. Stage 2, we do not see the pitting edema, we see non-pitting edema. And unfortunately, stage 2 is irreversible, does not resolve overnight, and there is going to be clinical fibrosis present. And in stage 2, this is the first stage where you're going to see severe skin changes. And then stage 3 is also known as lymphostatic elephantitis, or elephantiasis. And this is an accumulation of the protein-rich edema with significant increases in connective as well as scar tissue. Again, we're not going to see the pitting edema, but we're going to see non-pitting fibrotic edema. And there's going to be severe atrophic changes. There's going to be hardening of the dermal tissue, the skin folds are going to change, there may be skin tumors, and hyperkeratosis. And please note that lymphedema can be classified in 2 ways. It could be primary, which is usually 99% of the time idiopathic because we don't know what's actually causing it. Or it could be secondary, acquired due to some type of surgery or some type of chemotherapy or radiation therapy. With the primary lymphedema, there's approximately 15% of primary lymphedemas that happen during the early stages of life, especially shortly after birth. That's when it's usually noticed. So recapping on the previous slide, primary lymphedema is usually idiopathic in most cases. We don't really know what causes it. However, secondary lymphedema, depending on where it is, we can usually target what's causing it. So in the upper extremity, it's usually associated with mastectomies. So during a mastectomy, not only is the tumor going to be resected, there's going to be some good breast tissue resected, and maybe some vital components of the lymphatic vessels, and maybe even some lymph nodes are going to be resected out depending on the severity of the cancer. Also with a lumpectomy, if the physician notices a lump, a palpable lump, this could also result the curettage of scraping it out down the road. It could also result in a secondary lymphedema. And in the lower extremity, the incidence of lower extremity lymphedema usually occurs it's relatively high after inguinal lymph node dissection, and they usually do an inguinal lymph node dissection if there's a malignant melanoma that is metastasizing, and this has been reported in about 30% of the people. The first pathological condition that we're going to talk about that results from primary lymphedema is known as clippaltrinaneweber syndrome. So we don't know why this is caused. There may be a genetic component, there may not be. Most likely there is, because this syndrome is associated with problems with embryonic development. Not too much detail on what's going on with the embryonic development abnormalities, but there are issues. So the patient will suffer from lymphedema in both lower extremities, as you can see in the picture here. And look at this picture here. You can see there are a lot of skeletal abnormalities of the toes. The patient may suffer from hypertrophy of bones and soft tissues. The patient may form large hemangiomas and venous varicosities in the lower legs. The patient may also suffer from lymphangiectasia. And lymphangiectasia is a result of lymphatic hyperplasia in a deeper organ or localized area of a limb. And both lymphangiomas and lymphatic cysts are forms of lymphangiectasias. I do want you all to be able to differentiate a primary condition that we just saw on the previous slide versus a secondary condition. The secondary lymphedema, also known as lymphatic filariasis, this is also known as elephantitis or elephantiasis, however you pronounce it. And this condition affects more than 120 million people in 80 different countries throughout the tropics and the subtropics of Asia, people all throughout Africa, the Western Pacific, and even parts of the Caribbean and South America. And this is caused by a parasitic worm which is spread by mosquitoes. And this parasitic worm can grow up to 10 inches, and it can pass into the initial lymphatics and larger collecting lymphatics. And unfortunately, the greatest damage is done after the worm dies, and this can affect the patient, 5 to 10 years down the road after the initial infection. Because at that time, foreign proteins from the worm body are going to cause severe local inflammatory reactions that lead to severe fibrosis and scarring of the tissue. And this leads to total blockage of the larger lymph collectors. This total blockage results in massive swelling distal to that specific collection site. And local radiation treatment after surgery for cancer increases the incidence of secondary lymphedema, which I mentioned again. And you can see this may be, most of the time it's going to be unilateral. It may be bilateral depending on the invasion of the parasitic worm, but you can see the severe swelling in this patient's legs, and you can also see the skin folds. The skin folds are very important to make sure they're kept clean, because as the skin folds over, this creates a favorable habitat for lots of different bacteria and fungus, such as Lymphadenitis, to grow. So the skin folds need to be taken care of and washed and cleaned on a daily basis to prevent bacterial and fungal infections. This flowchart shows the progression from an at-risk or latent phase of lymphedema to the acute lymphedema that occurs after lymphadenectomy and or radiation treatment to the specific nodal area. So take a minute, go through this schematic, and look what happens. So again, this is going to be secondary lymphedema because this is caused by some type of medical procedure, versus primary lymphedema. Remember, that's associated with embryonic development that occurs shortly after birth, and it's idiopathic. We don't really know why that's occurring. And this schematic shows the whole pathological manifestation of how secondary lymphedema comes to result from starting from a lymphadenectomy to producing low output failure and systemic lymphedema. Now let's dive into the pathogenesis of lymphedema. So it can be caused by low flow edema. We've already gave the analogy of the highway being the lymphatic vessels, the cars being the lymph, and the toll booths being the lymph nodes. So if there's a car issue, if there's lymphatic transport inadequacies, the capacity is inadequate, that can result in lymphedema. If there's an increased lymphatic load, if there's too many cars trying to go through, a certain amount of toll booths, that can cause lymphedema. That could cause a backup of cars and traffic. If there's any blockage, if there's something on the road that prevents the cars even getting to the toll booth, that could result in upstream or downstream edema, depending on what we're talking about. If the lymphatic vessels dilate for too long, that could result in lymphedema, the swelling of the vessels themselves. And we talked about the individual subunits of the lymph nodes. If their valve flaps become incompetent and lymph isn't transported properly, that could result in lymphedema as well. And also if there's reflux that's happening, if there's protein-rich lymphatic fluid that gets refluxed into the tissue spaces, that could accumulate in the tissue spaces, resulting in edema as well. And some of the pathologic sequelae are listed on this slide for you. So along with the lymphedema, that's going to cause the noticeable and visible swelling and the general discomfort, the patient may suffer from chronic inflammation. The patient may also display a higher susceptibility to infection and may also have delayed wound healing. And the patient may undergo or have a condition known as lymph pump deterioration. So in lymph pump deterioration, although the number of macrophages is increasing, their activity is decreased in the lymphedema fluid for reasons that we don't really understand. But there are some theories that suggest that the chronic lack of essential nutrients, such as oxygen, or perhaps a toxic factor produced by the stagnant proteins or the damaged tissues, contribute to the deterioration of the macrophages. And again, the impaired transport mechanism. So the effect of lymphedema on the blood vessels causes a proliferation of new small blood vessels and the development of arteriovenous anastomoses. These new small vessels may leak as a result of abnormal changes in the total tissue pressure in the lymphadenous region, and that could cause further overloading of that specific area. And proteins, fats, and cellular waste products, and the 10% or more, depending on the situation, of tissue fluid volume that is not directly transported by the venous system has no alternative pathway from the interstitium to the venous system except the lymphatic system. So if there's excessive accumulation of these different things, that could also cause lymphedema and is part of the pathogenic sequelae. So listed here are the clinical manifestations, all the symptoms that the patient may complain of, and also some signs. So the patient so skin tightness could be a sign and a symptom. The patient could complain that his or her skin feels tighter, but you may also be able to see it if there's any type of elasticity. Loss of elasticity, I'm sorry. Numbness, this is going to be a symptom. Burning, aching, and pain, all symptoms. Decreased flexibility, both a sign and a symptom, because the patient may report it, but you can also see it if you've been with this patient for a good amount of time. Postural changes, a sign. You can definitely see how the posture changes. The patient may display neuromuscular deficits and oxygenation, the metabolism of waste and cellular debris impairments. That's going to be a symptom. So again, that goes back to the whole thing about the macrophages and the lymph pump deterioration. So again, although the number of macrophages is increasing, their overall activity is decreased in the edematic fluid. And again, these are things that we don't really understand, but because possibly the macrophages aren't getting essential nutrients such as oxygen, or they're getting some toxic factor that's produced by the stagnant proteins, this contributes to the deterioration of macrophages. And there's also a cognitive component. If you go to the clinic and, people can be very, conscious of looking certain ways, especially if they come with lymphedema that doesn't really look very normal. They're going to get a lot of glares and things like that. So it could lead to depression, anxiety, self-consciousness about the condition. So please be aware that there is a cognitive component to both primary and secondary lymphedema. This slide here shows a picture of a 30-year-old male with spina bifida and lymphedema secondary to paralysis and unsuccessful plastic surgery with a skin graft for a chronically itchy small keratotic lesion on the left anterior ankle crease. And in A, we can see this chronic ulceration that's complicated by a fungal infection of the ulcer. So the fungal agent is most likely Tinea pedis, and also severe swelling of the whole aspect of the foot and the toes. And you can see the hypertrophic fibrotic skin at the ankle and warty changes on the toes. So these are all manifestations that can arise with secondary lymphedema. And then B depicts what the patient looks like after 4 weeks of complex lymphedema therapy. So they debrided the ulcer, and they did lymphatic drainage, they did compression bandaging and other skin care. Unfortunately, the patient was not able to exercise because of paralysis, and the patient did do deep abdominal breathing exercises, and these actually did lead to modifying self-lymphatic drainage. And you can see that the wound healed completely and the infection actually resolved itself. So there's a lot to be said about deep abdominal breathing exercises and self-modification of lymphatic drainage. As the dermis of the skin thickens, the skin itself dries up and cracks, and ulcerations often develop. These ulcers may not heal because of the tension on the tissues from the edema. They also may not heal because of a decreased oxygen state, which could also be coupled with subcutaneous fibrosis and systemic chronic inflammation. As the skin folds, these areas become breeding grounds for both fungal and bacterial infections that can damage skin integrity. And the main fungal agent that affects these areas is known as Tinea pedis. So remember, we also see that in the athlete's foot, and John Madden could eradicate that with tough-acting connectin. So remember that, Tinea pedis, a simple antifungal can get rid of it. But in a patient who's suffering from lymphedema, you may notice alterations in gait. So the patient may present with different types of gait, including antalgic gait, where the patient's favoring the side that's not affected by the lymphedema. The patient may also have decreases in functional range of motion and a general lack of strength because the patient's probably not going to be walking on the side that has the lymphedema just because of the pain and the general fatigue. But one of the diagnostic criteria of lymphedema is a positive stemmer sign, S-T-E-M-M-E-R, stemmer. And you can clearly see a positive stemmer sign in this picture as this is a sign that's indicated by the skin folding. And this is actually a picture of a 22-month-old child with a history of primary lymphedema of the left lower extremity, which was diagnosed at birth. And again, the stemmer sign is the folding of the skin, and this is used for diagnostic purposes. We've beat primary versus secondary lymphedema into the ground. I'm just going to reiterate one more time. Primary is idiopathic, we don't know. Secondary is caused by some other medical manipulation, some type of disruption due to a surgery. And with primary lymphedema, we're going to have a diagnosis with a positive stemmer sign. So the patients may undergo all types of diagnostic imaging. They may get a venous Doppler, they may get an MRI or a CT scan, but it's really important for the PT to notice this and be an integral part of the whole medical care team in order to get the patient back to health and back to normal function. So you saw the case of the small child with spina bifida and the severe ulceration, how the patient was taught self-breathing exercise to modify lymphatic drainage. That's something the PT could definitely teach and educate the patient about, which could get the patient mobile if the patient wasn't paralyzed. So medications could cause this, and all of these reasons that I listed before, these are why it's really important when you get a medical history, to know the pathology, know why these conditions exist, so that you're able to recognize this and you're able to know how to review the patient's medical history in a detailed and systematic fashion. So the MRI and the CT are going to clearly show edema fluid in a lymph or a specific region, but these tests don't really give a good description of lymphatic function. And medications could cause that. Unfortunately, there are no known medications. Medications could cause lymphedema, but there are no known medications to cure lymphedema. Surgeons will try microsurgeries to alter lymphatic flow, maybe make some new anastomoses and try to get around the blocked areas. And there's also been debulking procedures to physically remove the excess fibrosclerotic connective tissue. These are all ways that the medical team is involved in medically managing the condition. So what should you look out for in patients who are presenting with lymphedema as a physical therapist? Well, definitely their medical history. The medical history will tell you a lot. And also be aware that these patients are extremely prone to local infection, even from a very minor trauma, very minor abrasion, or even an insect bite. And it's really important for the PT to educate the patient in risk reduction and proper skin care to minimize their risk for recurrent infections. The patient may also have circulatory compromise. So as you can imagine, if the venous and arterial supply as well as the lymphatic drainage is disrupted in the lower extremity, the rest of the circulatory system is going to be compromised. The heart's going to have to work harder to supply blood to the lower extremities. And there's going to be an elevated stress level in the patient, and there's going to be stress in the impaired lymphatic system. So the lymphatic system may undergo metaplasia or hyperplasia or dysplasia, depending on the severity of the lymphatic pathology. And I want you all to be aware of the differences between lymphadenitis versus lymphangitis. So lymphadenitis is infection of the lymph node, and lymphangitis is inflammation of the subcutaneous lymphatic channels. Infections anywhere in the body can actually lead to lymphadenopathies. When the lymph node becomes overwhelmed by the infection, the lymph node itself can become infected. And lymphadenitis can be classified as either acute or chronic. And acutely inflamed lymph nodes are most commonly localized in the cervical region in association with infections of the teeth or tonsils, or in the axillary or inguinal regions secondary to infection of the extremities. Lymphangitis usually occurs as a result of either hemolytic streptococci or hemolytic staph, or both entering the lymphatics and their channels from an abrasion or local trauma, wound, or infection. And this is what's depicted here. This is a picture of lymphangitis. So the involvement of the lymphatics is often first observed as a red streak under the skin radiating from the infection site in the direction of the regional lymph nodes. So look for the red streak and associate the red streak with lymphangitis. And the last pathological condition that we're going to talk about with the lymphatic system is known as lipedema. And this was first used to describe symmetrical swelling of both legs, and you can clearly see that in this patient here. And it's not necessarily a disorder of the lymphatic system, but there's some type of underlying etiology that's causing fat deposits, and this underlying etiology remains idiopathic. We don't know why this happens. Unfortunately, this condition is found almost exclusively in women, and it's accompanied by hormonal changes. If the rare case does happen and it's present in a male patient, it's accompanied by massive hormonal disorders. And note in the picture here that the feet themselves are actually free of edema, and the ankles and the lower legs have pitting edema. So these are all clinical signs that are associated with lipedema. So the feet are free of edema, and the ankles and lower legs are going to have pitting edema. And the patient also exhibits fatty nodules that you can kind of see are beginning to appear on the distal thighs. And as far as the pathophysiology of lipedema goes, well, generally there's just a decrease in elasticity of the epidermis. The patient's basement membranes, the vessels, will thicken. The patient may experience disturbances in vasomotion. Vasomotion is spontaneous oscillation in the tone of blood vessel walls independent of heartbeat, respiration, or innervation. The venal arterial reflex is going to be disturbed, and this is going to result in decreased vascular resistance and increased skin perfusion and increased capillary filtration. The pitting edema that you may see is due to decreased efficiency of the calf muscle pumping. And there may be many different histologic changes that the histologist or the pathologist may see. So he or she may see thinning of the epidermal layer, thickening of the subcutaneous tissue layer, fibrosis of arterioles, tearing of elastic fibers, dilation of both venules and capillaries, and both hypertrophy as well as hyperplasia of fat cells. And unfortunately, there's no cure, but the primary goal of therapy intervention in the person with lipedema is symptomatic relief and realistic improvement of the trunk and lower extremity function. So that is how the PT can be an integral component of getting patients with lipedema back to their normal function.